I will now briefly introduce Ross, who will then also say a few words about himself as well, filling in the blanks with whatever I missed. So Professor Ross White is Professor of Clinical Psychology at Queen's University, Belfast. His work focuses on global mental health with a particular focus or passion for understanding and improving the well-being of people who have been forcibly displaced. Over the years, he's worked closely with organizations like the World Health Organizations and the United Nations High Commissioner for Refugees, so UNHCR, to develop and evaluate psychosocial support programs for refugees. Ross was also the lead author of the Palgrave Handbook of Sociocultural Perspectives on Global Mental Health. I had the pleasure to contribute to this volume as well. It is thick. You can really injure someone if you whack them over the head with it. It's a really fantastic book with lots and lots of perspectives and different sort of chapters and insights. In 2024, he also published a popular science book titled The Tree That Bends: How a Flexible Mind Can Help You Thrive, which explores psychological flexibility and how that can foster resilience. But now, Ross, I'm handing it over to you, and I can see that still people are coming in, but we'll continue in the interest of time. So thank you again, Rob, very, very much for joining us here and for giving us this really important talk and conversation later. Thank you.
It's an absolute pleasure. Thank you for the invite. And yeah, I'm only too grateful and honored to have the opportunity to contribute to the vision of the network and of the centre, which are very dear to my areas of interest. So yeah, thank you for the invite. So yeah, helpfully, Hannah has really done the initial slide for me. Professor of Clinical Psychology at Queen's in Belfast, which is part of Northern Ireland. I'm very proudly drinking from my Northern Ireland cup, which is the Giant's Causeway, which is a great tourist attraction when you do, not if you do, when you come to Northern Ireland. I have expertise in a range of different methodologies. As Hannah was alluding to, I've got a particular interest in evaluating intervention. So I do have lots of clinical trial methodology experience. I'm also interested in assessment and in particular developing novel assessment instruments so that we can really determine levels of well-being and quality of life in particular populations. And with that, I do have expertise in qualitative research methods as well, including reflective thematic analysis and also interpretive phenomenological analysis, or IPA. I have a particular interest in a form of psychological intervention called acceptance and commitment therapy, or ACT. It's not referred to as ACT, it's instead referred to as ACT. Now, the relevance of that and me highlighting that at this stage in the presentation will become clearer as we progress through the presentation today. And Hannah mentioned the book, The Tree That Bends: How a Flexible Mind Can Help You Thrive, which draws on principles from ACT and how they could be helpful in your lives and the lives of others. I was previously the founding director of the MSc in Global Mental Health at the University of Glasgow, and we got up and running with that program in 2012. And that was at the same time that King's College and London School of Hygiene and Tropical Medicine were going live with their MSc in Global Mental Health. And it's great to see that that program continues to run now as well. Hannah had mentioned the Magnus Opus, the tome. It is, I think, about 800 pages long. So it would do your foot some damage if you were to drop it. But I hope there are helpful resources and real-world experiences of projects that have really sought to speak to social science and also humanities perspectives on global mental health. I think there were concerns initially when global mental health emerged that it was quite biomedical in its focus. And there were concerns about it being a form of medical imperialism where we were getting flows of knowledge and practice coming from the global north into the global south, when in actual fact, we in the global north have, I think, a lot to learn from understanding and responding to mental health and well-being and how it's done in the global south. We are obviously focusing on supporting the mental health and well-being of forcibly displaced populations. Each year, the United Nations High Commissioner for Refugees publishes a document called Global Trends, which is reflecting statistics in relation to forcible displacement and how those figures are stacking up. Now, I've been looking at these figures for 15 years, and as you can see in the graph here, certainly over the last 10 years, we're seeing a steady increase in the numbers of people who've been forcibly displaced. Now, I'm sure that will come as no surprise to many of you in light of your interests, but also your awareness of the state of the world at this time and some of the pressures that people are experiencing, both in terms of climate change, in terms of conflict, in terms of global instability and economic instability. So we do have an estimated 123 million people who've been forcibly displaced worldwide as of the end of 2024. Now, the vast majority of those, as you can see from the graph here, are internally displaced people. So people who have been forced to leave their home but haven't crossed an international border. Then we have refugees being the next largest group who have had to flee to another country. Then we also have asylum seekers represented and also Palestine refugees under the UNRWA's mandate. And then there is a category about the same size as that, which are people in need of international protection, which is an additional status that can be awarded to people. But the numbers are staggering. The Global Trends document highlights that nearly 3/4 of the people who are forcibly displaced are hosted in low and middle income countries. And that is the global majority, that those countries constitute the largest proportion of the global population. And we can do well to remember that. But yeah, 3/4 of the people who are forcibly displaced are being accommodated in countries where resource is already scarce. I think it's fair to say. Now, over 2/3 of the forcibly displaced people are hosted in neighboring countries. And again, that's important because I think the way that the press represents migration and the impact that that can have in countries like the UK or Ireland isn't representative of the scale of the problem being faced in other parts of the world, particularly low and middle income countries. Interesting stats here as well about the proportions of forcibly displaced people being hosted in various countries. So 1 in 8 people currently living in Lebanon has the status of being forcibly displaced. And yeah, I think that's interesting to consider. Small countries, comparatively small countries, having to absorb large numbers of forcibly displaced people and the impact that that can have on the resources available within those countries. I've cited a couple of meta-analyses here. The first is looking at the mental health of refugees in high-income countries and the prevalence of a range of different types of mental disorders. So you see that levels of anxiety can be elevated in forcibly displaced populations relative to the host country, as can levels of depression and certainly levels of post-traumatic stress disorder. I did mention that the vast majority of forcibly displaced people are accommodated in low and middle income countries, the global south. And there has been a meta-analysis conducted to look at the levels of mental health difficulties in those settings experienced by forcibly displaced people. And again, we're seeing a similar picture that levels of post-traumatic stress disorder can be elevated relative to the host population, as can milder forms of mental disorders such as depression and anxiety, often referred to as common mental disorders by virtue of the fact that they are the most frequently occurring forms of mental health difficulty. And why might that be the case? Well, there's been growing interest over the last number of decades in what are referred to as social determinants of mental health difficulties. And it's been great to see international organizations like the World Health Organization publishing documents focusing specifically on social determinants of mental health difficulties. And if we think about the range of social adversity that forcibly displaced populations can experience, we start to understand better why those numbers are as high as they are. So let's think about three different phases where these determinants can impact the experience of forcibly displaced people. There's the pre-migration phase prior to leaving the country of origin. Those experiences could include exposure to war, torture, and persecution, which we know can be very traumatic and breed a lot of uncertainty and feelings of precarity. And that uncertainty and precarity really spills over into the second phase, which is the migratory journey itself. People can be exposed to deprivation experiences that are harsh, potentially degrading. People can be subject to exploitation, and resources can be hard to come by in terms of basic needs. So clearly the migratory journey itself can be a very difficult experience. And then the final of these three phases is the post-migration phase. Now, when people come to a host country, they may experience stigma, discrimination, a sense of isolation, wondering as well about where loved ones might be, and that sense of being dislocated from previous social networks. They also have to deal with experiences and processes that can be quite adversarial. And that adversarial nature of those experiences can mimic experiences they've had previously. Excuse me, including feelings of persecution. So, yeah, we have to think as a society what we may be doing in terms of re-traumatizing people by virtue of how people get treated whenever they come to countries like the UK or Ireland. Now, amidst all of these numbers and figures and these theories, we also have to really remember the people involved, the very human stories that sit at the heart of this, the lived experience that people have. And I think sometimes it's easy to lose that sense of the lived experience whenever we're talking about numbers and research findings. So I've included a couple of important images here, some of which may be familiar to people, but just take a moment to notice the age range of the people in that image. You can see in the foreground on the right, a young child being comforted by an adult. You can see a child being passed between the boat and the land. You can see adults on the boat, and you can see some level of suffering being very obvious and apparent in the faces, the reactions, the posture of those people. And the next image is from a Palestinian refugee camp in Syria that was subject to devastation by virtue of the conflict that occurred in Syria. And these people were being displaced from the settlement that they had been displaced to, or their parents or grandparents had been displaced to. So you have this double whammy of displacement. But that's literally a sea of humanity whenever you look back down through that image. I want to emphasize that being a refugee, an asylum seeker, or indeed an internally displaced person is not a diagnosis. Yes, we can see levels of mental health difficulty elevated in forcibly displaced populations, but the majority of people are able to find ways of coping or dealing, or maybe don't present even to services. So it's important to recognize that in spite of the adversity, in spite of the traumas that people can experience, there are also incredible levels of resilience. And that's an important area of research as well, trying to understand what we can do to help people develop a sense of resilience in spite of the difficulties and adversity they experience. Doesn't mean that we step away from bringing about the societal change that we need to bring about in terms of how people are treated, but it can certainly be an important element of helping people. I want to emphasize, and I often emphasize, that mental health and well-being in terms of forced displacement is not merely a health issue. It's certainly part of that, but it's a human rights issue. It's about ensuring opportunity for participation, full participation in society. It's about tackling discrimination and stigma that people can experience. It's about trying to preserve and optimize human dignity, agency, and empowerment. So, not just a health issue, it's a human rights issue. And I'm very interested in human development frameworks and how they can speak to this area of human rights. And I've been particularly interested in the capability approach, which was developed by Amartya Sen and subsequently Martha Nussbaum. So Sen originally proposed it as a human development framework, and he won a Nobel Prize in economics for the pioneering work that he did around this. But Martha Nussbaum really developed it further in terms of using it as a framework to better understand quality of life and experiences of well-being. And it's really about ensuring that we foreground people's freedom to engage in valued forms of being and doing. And that's determined by them, not imposed upon them. So, what constitutes a good life for the person? And doing our utmost to try to promote circumstances that allow that to unfold. And if you're interested in learning a bit more about the capability approach and its relevance for forced displacement, then this paper would give you an overview of the work that we were proposing. And it's available at that link, and the slides will be circulated following the presentation today. Now, this is an incredibly detailed diagram, and please don't get lost in trying to blur your focus so you can potentially read a couple of words. I know it's very small print. It's a figure taken from the paper that really helps orientate the reader to what the capability approach is about. And that's really the bottom piece around goods and resources, what are called conversion factors, in this issue of freedom, which includes what are referred to as capability sets and the individual's sense of agency, to then finally what are referred to as achieved functionings, the opportunity to engage in valued forms of being and doing. And what we did was really draw out the social ecology of forced displacement, which is the top element of the diagram, really looking at the microsystem, which is factors specific to the individual. The mesosystem, which are the sort of immediate social environment that the person is situated in, for example, family dynamics, to also include the exosystem, which sits around that, so community norms and beliefs, for example, and then the macro system, national and international law, global economic downturns, etc. So the individual is subject to influences across the range of that social ecology. And it's important for us to recognize that really interventions need to be happening at each of those levels. Otherwise, you're only tackling part of the issue and not addressing it all. So, yeah, those different levels of the social ecology can impact on people's ability to realize capabilities and achieve their functionings. So it's important for us when we're thinking about supporting mental health and well-being of forcibly displaced people to really think across the different levels. And it is about coordinating support, multi-agency support, potentially around facilitating positive social interactions, looking to improve the economic standing of forcibly displaced people through, for example, poverty alleviation programs, giving people the opportunity to learn skills, learn language, so that they can prosper and indeed the generations to come can prosper. Access to transportation so that people have the opportunity for mobility to avail of educational opportunities that might be open to them to interact with each other. Affordance of legal protections. So having that sense of safety and security in terms of their standing in the law. So coordinating support across those different layers is very important. Does require a lot of coordination, clearly, and thought and planning. It's not without challenge, but it's important for us to explore those opportunities. So let me turn now to some examples of measure development which are relevant for supporting the mental health and well-being of forcibly displaced populations. So the first scale that I want to focus on is one that's called the Good Life in the Community scale, or GLICS for short. And this was developed by Dr. Corinne van der Boer as part of her PhD studies that I was lucky to supervise. And she conducted qualitative research with 16 female refugees living in the UK, asking, what does the term the good life mean to you? So this is very much based on the capability approach and having that inductive bottom-up understanding of what matters to these communities. Interestingly, the qualitative work identified three main themes that then subsequently became subscales of the good life in the community scale. And the first one is access to resources. And an example of an item from the good life in the community scale that taps into this issue is I am able to access courses to help build my skills and talents, for example, art classes or dance classes, and the person would indicate how strongly they agree or disagree with that comment. The second theme or subscale was called belonging and contributing. And an example item from that scale is I am able to feel I'm a valued member of the community here. Again, the person would indicate their level of agreement or disagreement. And these are just sample items. Obviously, there were multiple items tapping into each of these three subscales. So the third one is independence. I'm able to read and write in the language of this country. So clearly you can see the relevance of these issues for the person. If you're interested to read more about the good life in the community scale, the link for the paper is here. And indeed, if you go to that link, you should be able to access a copy of the scale. And thanks to Karine for making that available at the link. So good life in the community scale, a well-being measure based on the capability approach that seeks to have that inductive understanding of what a good life means to refugee communities. The next scale is called the Migrants' Perceptions of Public Attitudes scale, or MPAS. And this was developed by Jess Deol, a doctorate in clinical psychology trainee that I supervised at the University of Liverpool, and also most recently by a doctorate in clinical psychology student based at the university here in Belfast, and that's Lynn Walsh. And the MPAS is about tapping in to how forcibly displaced populations feel they are viewed by the public broadly. So there have been lots of surveys asking the general population, what do you think of forcibly displaced populations coming to this country or other countries? But we haven't necessarily had a way of determining, well, how do you, as communities who've been forcibly displaced, feel the public are viewing you? And you can see how that sense of being evaluated by the community at large could well impact on the mental health and well-being of people who have been forcibly displaced. So I've included some example items. This is not the entirety of the scale. It's just a bit of a screen capture, capturing 5 of the items in the scale. And yeah, Lynn's work that was completed recently did a confirmatory factor analysis of the measure, which is currently sitting at 11 items in length. So this is just short of just shy of the half of the measure, but it gives you a sense of what it's happening into. Now you can imagine the climate of these current times and how important I feel a measure like this might be for understanding the lived experience of forcibly displaced people at the moment and the othering that people are experiencing at the moment, the in-group, out-group sort of dynamic that gets reinforced in the tabloid press in particular. So finally, what I really want to transition into now is that focus on intervention work and efforts aimed at supporting the mental health and well-being of forcibly displaced populations. So around 2017, the World Health Organization published a document that was entitled Scalable Psychological Interventions for People in Communities Affected by Adversity. And I think this went through a number of initial iterations, but really it is focusing in on these humanitarian crises and the accommodation of people who have been displaced, recognizing that those populations can experience difficulty and really exploring what could be effective and cost-effective ways of supporting those populations. And there are a suite of different interventions that the WHO have introduced by way of these scalable interventions. So scalable meaning it can be brought to large numbers of people. So the original program that was developed and evaluated was Problem Management Plus, which is based on cognitive behavioral techniques, but also problem solving approaches. And it's been evaluated and shown to be effective. There's also Thinking Healthy, which is an intervention for mothers who have given birth to children, recognizing that the first 1,000 days of a child's life are so important to its future development and doing the utmost that we can to support the mental health and well-being of the mother and the child. And then most recently, there's Self-Help Plus, which is a guided self-help intervention delivered to groups, up to 30 people in a group. Guided means that it's really driven by audio recordings, but there are two lightly trained facilitators there to ensure the smooth running of the groups, to answer any questions, and to show some of the materials that are used in the intervention. But it was designed really to be led principally by an audio recording that is played and instructs people to follow some of the guidance. Self-Help Plus is based on acceptance and commitment therapy, which is the therapy I mentioned at the top of the talk, ACT. And I was consulted by the WHO along with a range of other people about the development of these interventions. These scalable forms of intervention are intended to be amenable to cultural and linguistic adaptation. And in each of the evaluations that the WHO did, extensive work was done with local people to try to ensure that the materials were culturally adapted and that they were meaningful and appeared relevant to the populations that they were being used with. And of course, linguistic adaptation to ensure that people could understand and follow the materials well, and that it was expressed in a language that people could understand, that they used routinely. So yeah, these scalable approaches were intended to be adapted for cultural and linguistic context. So just to focus in on Self-Help Plus as a package, I mentioned it was a 5-session group intervention, and it is a guided form of self-help. But I wanted just to give you a bit of a description of each of the sessions and what the sessions focus on. So it just take a moment at this stage to read through what the sessions covered. So hopefully you'll get a sense of what the intervention was aiming to do, but you'll also get a sense of how this in isolation will only be effective if it is combined with these other areas of intervention, coordinated support. Like we can help people become more resilient, but ultimately, if we're not changing the context around the person, then what's the point? The context will continue to harm them. So, yeah, it's often referred to as the resilience paradox, that in focusing on building the resilience of individuals, we let the system and the broader social ecology off the hook, which actually is one of the primary, if not the primary driver of the distress and uncertainty that people are experiencing. So again, really important to recognize this is not a panacea, but as part of coordinated support, it can play a role potentially. And that's what we were seeking to find out. So the materials are intended to be visually accessible, light in language, using metaphor that would be meaningful, illustrations adapted for cultural context, etc. I've been involved in 3 major trials evaluating Self-Help Plus. The first was conducted in northern Uganda with South Sudanese female refugees, and that was led by Vitzay Tall, and Self-Help Plus was shown to significantly reduce levels of distress that the populations were experiencing. There were subsequently 2 sister trials, one conducted in Turkey with Syrian refugees, and then one conducted across 5 EU countries. And again, the findings were positive. Self-Help Plus was shown to prevent mental disorders from developing at a significantly greater rate than the control arm was, and also shown to reduce levels of pathology and also boost levels of well-being within the populations. And by virtue of the positive findings in these studies, Self-Help Plus has been released and is freely available through the WHO portals and has been translated into, I think, 20 different languages and culturally adapted for a range of different settings. So if you're interested, please do check out some of the materials. Interestingly, the WHO developed a form of Self-Help Plus into a purely self-help version, no guided audio or facilitation by lightly trained individuals. And that was made available during COVID as a document called Doing What Matters in Times of Stress. So some people may have come across that version of it as well. So the link there will take you to the different language versions of the intervention. So forms of psychological support clearly have a role, but I'm also interested in psychosocial intervention. I highlighted the important role that social determinants play clearly in the experience of forcibly displaced populations. So psychosocial interventions aim to address some of those determinants through a range of social activities designed to foster psychological improvement, such as allowing people in group to share experiences, to foster forms of support for each other. It's also about awareness raising and educating people about processes linked to mental health and well-being. There's the Mental Health and Psychosocial Support Network, which has done extensive work to collate lovely case examples of psychosocial interventions across the world. So please do, if you're interested, check out the link there. And there are a range of guidelines for developing, delivering psychosocial interventions for particular populations. For example, UNICEF have specific guidance about psychosocial interventions for children and families. UNHCR have specific advice around psychosocial interventions for forcibly displaced populations as well. So I want to conclude today by talking about a project that I was involved in called CoStar, and it is community-based sociotherapy adapted for refugees. So that's CoStar. And we conducted this trial with Congolese refugees who were being hosted in Uganda, in Changwali, and also in Rwanda in a camp at Gahembe. So just by way of context, many of you will be aware that the Democratic Republic of Congo, or DCR, has experienced a number of major conflicts over the past 20 years, and the conflict continues there to this day. And it has resulted in large numbers of people being forcibly displaced. Just in terms of the local geography, you can see at the heart of the map here, you have Rwanda and Burundi. And then to the west of Rwanda, you have the DRC, which is a huge country. And then you have Uganda to the top right of the diagram. And this area of Central East Africa is referred to as the Great Lakes. And you have Lake Victoria, Lake Edward, there's Lake Albert as well. You can obviously see where these lakes have taken their name from Victorian members of the royal family, which says a lot about the colonial history and the ramifications of that history that echo on today. So there are clear indications in the research that people who have been displaced from the DRC are struggling in terms of mental health and well-being, and indeed populations that have been conflict affected that remain in DRC are also struggling with their levels of mental health and well-being. Not all, but significant proportions. So community-based sociotherapy owes its roots really in terms of its recent history to post-genocide Rwanda, and it was used to promote community healing in the aftermath of the genocide. Broadly speaking, the 15 group sessions are divided up into 6 phases, which focus on safety, trust, care, respect, new life directions, and memory. Memory comes last, if you like, because it requires that bed, that foundation of safety and trust and care, because it does involve reflecting and dignifying past experiences that people have had. There are a number of principles that guide the conduct of CBS sessions. It's facilitated by 2 people drawn from the local community who are trained up. And we were interested to see whether it could be used to support the mental health and well-being of Congolese refugees. So it was a cluster randomized controlled trial. The primary outcome measure was levels of depressive symptomology as measured by the PHQ-9. We were aiming to recruit 1,000 participants across 70 different clusters, which were like villages. So to avoid contamination or leakage of the intervention from individuals to other individuals, we instead randomized villages so that the people living in those villages had the opportunity to all receive the intervention. So that's a form of randomized controlled trial that helps to allay some of the concerns about people leaking some of the intervention into the control group and confounding some of the findings. So enhanced care, as usual, also they met in group 15 weeks, and they met to receive camp updates, but also information about the Sustainable Development Goals as well, which kind of sounds a bit unusual, but the UN Sustainability Goals uh, directly impact on the lived experience of people in the global south to an extent potentially far greater than they do to people living in the global north. So important that people have an awareness of what the priority areas are. So we had a range of different partners. There was community-based sociotherapy Rwanda, who have expertise in the intervention and delivering it. There's the UNHCR, and then Hijra was the psychosocial partner in Uganda. So this was a visit to Gihembe refugee camp in Rwanda at the beginning of the trial. And then a visit to the team in Changwali in Uganda. Definitely had less grey hair in my beard before this trial started. Not easy doing clinical trials in remote settings, never mind in settings where people have experienced forced displacement and their ability to be accommodated in those settings continues to be questionable. So, for example, towards the end of the trial that we conducted, Gihembe refugee camp was closing and everybody was being relocated across country. So, yeah, it just, and on a very human level, it served to emphasize how difficult the lived experience of people can be. There are a range of different papers reporting on the work that we did, some qualitative work, which was really about trying to understand local context and really ensure that we were basing our approach on a nuanced understanding. of what a good life, for example, represents to people living in these settlements in both Rwanda and Uganda. And then the work that we did to translate and contextually adapt and pilot the assessment measures that we were using. We wanted to try to be as culturally sensitive as possible. And this is the protocol paper for the cluster randomized control trial. And we're just in the process of working on amendments to the paper that reports on the findings of the trial. So yeah, over 1,000 people were recruited, and 81% of those completed all assessments at the primary outcome time point. So retention levels were reasonably good. We didn't find a significantly superior effect of community-based sociotherapy compared to enhanced care as usual on levels of depressive symptomology. And we can discuss why that might be the case, but yeah, I don't think community-based sociotherapy is a mental health intervention per se. It is a psychosocial intervention. Um, so on reflection, the ability to bring about change in levels of psychopathology or levels of mental health difficulty could potentially be limited. Interestingly, we did get significant effects on secondary measures, including the level of subjective well-being and, unsurprisingly, perceived social support. There were no adverse events recorded on the trial, so the intervention seemed to be safe and well accepted, and no adverse events in that sense. So just a bit about the work that we did around the psychosocial intervention with Congolese refugees. So some important takeaways. It's important to recognize that the majority of forcibly displaced people are hosted in the global south or low and middle income countries, as it's referred to in some settings. Refugees and asylum seekers can experience elevated levels of mental health difficulties. The research is clear on that. The events before, during, and after migration are important. Factors that can positively impact on mental well-being potentially remain poorly understood. Corinne van der Boer in her work conducted a systematic review looking at predictors of quality of life within forcibly displaced populations. And it was, I think, the first review of its kind. Focus had historically been on really predictors of ill health or distress. And it's important that we understand what contributes to good health and well-being. Interventions can reduce the stress and prevent mental disorders in forcibly displaced populations. The studies I've focused on have been quite deliberate in their focus on refugees specifically, but I think that applies more broadly too. Multi-agency support is crucial. That idea about coordinating support and intervention across the different layers of the social ecology, from the micro up to the macro, is important, and we mustn't lose sight of that. So important to acknowledge my collaborators, and it would not have been possible to do this work without them. And I've learned so much from my collaborators, grateful for their patience and perseverance through good times and bad. So yeah, I wanted to include a slide acknowledging those people. So thank you everybody for being here today, your patience and willingness to listen. And I look forward to just engaging in some conversation and some questions that you might have.